but the one which is a standard was the standard used in the DCCT, which is high performance liquid chromatography, which is using chromatogram. But there are other ways, many ways of determining it, like immunoassay, enzymatic methods, calibration electrophoresis, Bornet affinity chromatography, and point of care instruments. But point of care instruments can use any of the above mentioned mechanisms of determining hemoglobin A1C. And they are the HPLC, that's high performance liquid chromatography, is a standard which is used in the DCCT. And they have the different methods have their own benefits and drawbacks. And especially when you measure the hemoglobin A1C variants, most of the methods may have difficulties in determining, and the Bornet affinity chromatography is believed to be better, especially when hemoglobin A1C variants are suspected. And the other is point of care instruments, which are very, very important. I will come to this later. They are defined as clinical testing close to the site of the patient care using portable instruments. That's why what's called by a point of care instrument. And it aims to provide immediate results at the time of patient consultation. That's their benefit. And it enables therapeutic decisions to be made as earliest and decreases patient visits because they are done immediately and the results are available immediately at the site of patient care, and they are easily portable. They can be used in primary health care, so their importance is very, very significant in those primary care centers where we are unable to establish an advanced laboratory setup. And they use a drop of capillary whole blood collected via fingerprint, like we use to determine the blood glucose level on glucometers, and use methods of either structure or charge of the glycated hemoglobin A1C, and methods which I have mentioned previously. And these are very, very important things, ways of determining hemoglobin A1C, which are now have actually been standardized and have been approved now for use. And coming to the hemoglobin A1C variants, they are results of a point mutation in the gene which is responsible for hemoglobin synthesis. And there are many, many, many variants known. And most of them, fortunately, are usually silent. They don't express unless their impact was on RBC survival or they interfere in the assays. And they interfere in various methods, plus when they are clinically apparent, they interfere in the RBC lifespan, which is very important in the determination of hemoglobin A1C. But fortunately, as I've said it, most of them are silent. There are different types that fetal hemoglobin A1, 2 alpha and 2 gamma genes, adult hemoglobin A variant, 2 alpha and 2 delta genes, sickle cell disease, that's HBS, which is very important because when it's clinically active, it's associated with significant destruction and interferes even in the hemoglobin A1C assay. It gives you a falsely low result. And there are also other hemoglobinopathies which are important. And there are a group of inherited disease that's caused, as I've said, by point of care mutations. And the importance of this is because some of them are apparent in some areas, geographical areas. Those physicians who live in those areas should be aware of their interference in the possible hemoglobin A1C determination, and adjustments should always be made when you use hemoglobin A1C in clinical decision making. And their interference, they alter gyration, interfere with assay, and they cause red blood cells so that they can interfere on the results that you get from hemoglobin A1C. And the other is because once hemoglobin A1C was invented, actually, it has been used serially for decades. But the problem with hemoglobin A1C is it varies from center to center. It varies from instrument to instrument. And because of its significant role in decision making, there was a need for standardization, because when the same sample was done in different laboratories with different equipments, there tends to be a variation significantly, especially before 1997. And before 2010, and after 2010, there was a consensus statement for the need of standardization. That means hemoglobin A1C should be standardized. That means the standard to certain clinical laboratories, which are used as reference laboratories, and all other instruments which are used to determine hemoglobin A1C must be certified, and they send samples to these central laboratories, and their accuracy should be determined. That's one, what's called standardization, and this is done by the National Glycated Hemoglobin Standardization Program. And the standardization goes to the level of the DCCT, because that was a high standard, and the DCCT and the UKPDS, and this is done by Central Primary Reference Laboratory, as a core laboratory in the world, where samples are taken to this laboratory and they are checked for their accuracy. And this is very, very important because hemoglobin A1C is used as a reference in decision making, so we must have a clear result. So that is the purpose was that was the purpose of standardization. And finally, I will go to the point of care testing, which we believe will contribute significantly in the primary care setting, as I said, because it is very fast. It can be done at the point of patient visit, and it doesn't need a sophisticated setup because it's portable. So it can be delivered to the primary care. It doesn't need a big space for to be allocated for this. So we advocate hemoglobin A1C testing by point of care, which is now being accepted in several decision makers and institutions. So that is very important in the primary care. So what are its benefits? Improved diabetes management and glycemic control, because its rapidly availability for hemoglobin A1C results was associated with an increasing frequency of treatment, intensification, and decrease in hemoglobin A1C levels. Again, these point-of-care machines can be standardized, and most of them are standardized. They pass several standardization procedures, and they must get accreditation before they are being used. And nowadays, even they are being used for diagnosis, not only for follow-up. Their benefits, they have high patient satisfaction because it's immediate. The results can be available in 5 minutes, and we don't need to appoint patients. And this is important because you can make decision-making immediately at the site, at the spot, and provide and discuss hemoglobin results face-to-face, because when the patient sees their results, their impact on to be part of the decision making will improve. And they are really cost effective because they are portable, cost effective, and they are associated with an increased patient outcome. So we strongly recommend their use in the primary care setting, and they have shown to benefit significantly and to improve diabetes care. So in summary, primary and community care is increasingly at the forefront of delivering diabetes care, and hemoglobin A1C provides an estimate of an average blood glucose, which is used in diabetes diagnosis and follow-up. And studies have clearly demonstrated that glycemic control measured by hemoglobin A1C predicts outcome, as we have seen it in several studies. And most organizations nowadays recommend hemoglobin A1C in the diagnosis and follow-up of patients, of diabetic patients, and the National Glycated Standardization Program certifies hemoglobin A1C methods using specific method criteria and to decrease variability in the measurement. And they are becoming very tight because of its importance in decision making and its variability. And clinicians need to be aware of the conditions that affect hemoglobin A1C results, which is very, very important, especially in some geographic locations and in some patient scenarios like severe anemia, renal failure, alcoholism, and the like. And point of care testing improves diabetes management and glycemic control. And thank you. This is my presentation, and I'll accept some questions if you have. Hello, Gracia.
Thanks, Dr. Getahun. After listening to Dr. Getahun on the role of hemoglobin A1C in the management of diabetes, and you can send your question to the chat box, and we will select one or two questions for Dr. Getahun to answer. Yeah, we can check the chat box. There one question. Dr. Getahun, could you please answer how do you see POC HbA1c improving patient outcome compared to traditional lab-based method in primary care testing?
Yeah, yeah. Yeah, I think point of care, especially their use, is in the primary care setting because the previous laboratories need special setup, and the point of care machines, the result is immediate. They are standard. The problem was standardization, but nowadays they are standardized. They are portable. They can be taken anyway. So they are very, very important in the improvement of care in diabetes. And for example, in our country, in the Ethiopian Diabetes Association, we have distributed point of care machines to most of the centers that we have, to more than 60 centers, 60 branches under our supervision, and we have seen their impact improving in diabetes care because without having hemoglobin A1C determination, it is very difficult to decide and to improve outcomes and to prevent complications. So, and it's, as we know, it's very difficult to have the older machines everywhere in all hospitals, especially at the periphery. So point of care machines are very important and they contribute significantly to the improvement of diabetes care. And we have seen it in Ethiopia also.
Thanks. And another question is, Abinat asks the question, what is the accessible margin of error for POC HbA1c test in clinical decision making?
What that? Can you repeat the question?
Okay. What is the accessible margin of error for POC HbA1c test in the clinical decision making?
Yeah, that's important in clinical decision making because treating diabetes without knowing hemoglobin A1C is very, very difficult. As I've seen in the previous studies, this is hemoglobin A1C, which shows you a control over 3 months because we see patients on appointment and we can't decide, we can't, based on simple determination of fasting or random blood sugar for drug dose adjustment. And we have seen that hemoglobin A1C is associated with complications, strong complications, and it shows you a control of like 3 months. You can have appointment every 3 months, determine hemoglobin A1C, and if it's not in target, it shows you that you must make a decision making to escalate treatment and to treat patients to target, which is believed to reduce complications. And that's the main purpose of treating patients with diabetes.
Thanks to Dr. Getahun for your excellent answers to the question about the POCT. And then let's move on to the topic 2, pros and the pitfalls of POCT in primary care. Let's welcome to Dr. Roger. Hello, Dr. Roger. Are you ready to start?
Hi.
Hello.
Yes, I can share my slides.
Yeah.
So thank you very much for the introduction and for this great speech of my colleague. I will slightly touch on HbA1c later on in the presentation, which I could say is a kind of overview of different point of care tests, studies and implementation work I've been doing in the last 20 years. So I'm a practicing family physician, taking care of those patients. And I often visit them they all live in mills. As you know, in the Netherlands, we all live in mills and we bring flowers to our wives every day and we walk on wooden shoes. And as you see on the right side in the red circles, these are the areas I've been working, Maastricht University. And then I worked also for different laboratories in Eindhoven, Utrecht and Rotterdam. Dealing with over, let's say, 45% of the patients in the Netherlands. So these labs are called primary care laboratories. This gave me an ideal opportunity to implement point-of-care testing throughout this southern part of the Netherlands. I currently live and work in the Eindhoven area. And as you see, the half of the Netherlands is below sea level, so it's quite tough to work and live below sea level and have a hard time walking when you have a tail like you see on the left side with this woman. So that's the basic situation in the Netherlands, with a small joke. And more seriously, you can say that being a huisarts or family physician means that is a job which is called solid as a rock, because we are quite important for our healthcare system, also dealing with every diabetes type 2 patient, for example, together with our practice nurses. So it's a strong position we have. So I'm aware that it may be different situation in Ethiopia or throughout the world. We have a strong set of guidelines, over 100 guidelines. That means that if you have some scientific proof, you can more eagerly and easily innovate, because when you put it in the guideline, normally the reimbursement will also follow later on. Well, if it comes to the future challenges and developments, I think this is true for many countries in the world, that we get this double aging population. But and we see a more decentralized care, so care taken out of the hospitals into primary care, which of course gives a unique opportunity to introduce point-of-care testing, which is very much needed. But before we talk about POCT, we have to put it in perspective of the diagnostic work we do in primary care routinely. And you see here above 100 faces of people with a healthcare problem. And on a regular Monday, I have to give some answers to all those problems those patients are facing, not only in a consultation, as you see in the picture, but also, for example, a letter of a specialist or a laboratory test which you need to interpret and to check if you have to change management. So you can say it's quite busy for a regular day. And that makes it also hard to diagnose properly, because if you have time constraints, that gives some pressure on your diagnostic process, and that's not very favorable. So it often leads to more proactive decisions, for example, prescribing an antibiotic. So when you come to the definition of point-of-care testing, well, that's a very broad. You can put it very broadly. It's every test done at the point of care. But normally we talk about laboratory tests, as you see in the picture. Even in the older days, a urine check was a normal point-of-care test. And when I was writing a guideline on point-of-care testing in primary care, together with my colleagues from clinical pathology and microbiology and the laboratory world, we decided that we should put some stress on the fact that it is a process. It's not like a simple test, but it's a process, and every detail of this process should be taken care of during or before and after a consultation with the patient. In a more scientific way, we have asked various experts in a Delphi method to come to a final definition of a point-of-care test. And there we put the emphasis on the fact that it supports a clinical decision-making process and a shared decision-making process with your patient. Talking about diagnostic aspects, we all want this test which has a 100% sensitivity and specificity, right? It's the ideal test, and with the area under curve of 100%, if you talk about it statistically. But the strange thing is, particularly in primary care, no test is perfect. So if you talk about taking your temperature to see if this has diagnostic ability to diagnose pneumonia, this would be the curve for fever. If you talk about introducing a point-of-care test like C-reactive protein, we found this curve, this blue curve, much bigger. And then the strange thing is that the general audience often reflects to this, let's say 85% area on the curve by telling us it's not a perfect test, so we shouldn't use it in primary care, which is ridiculous, of course. That's why I would like to state that goals for precision and accuracy should be dictated by the clinical need and not by analytical limitations, because we need better tests in primary care. I'd like to give you the most successful example. I'm happy that I was one of the front runners of this development, the introduction of this new ways of point of care testing for patients with acute cough problems. And it's always a good thing when you have a problem. That means in this case, if we talk about the problem of AMR, antimicrobial resistance, we need to do better. We need to prescribe less and only in selected cases, because it's already leading to a lot of deaths throughout the world, as you can see from this Lancet paper. So we have a problem, and the problem is also that most of those antibiotic prescriptions are done in primary care, and mostly for, let's say, non-severe lower respiratory tract infections. And this is a wrong message to our patients, of course, when we keep on prescribing. So the strange thing is, why do healthcare professionals prescribe that much? Well, there are all kinds of cultural and patient and doctor-related factors, for sure, that are important in this respect. But it is also a problem of diagnostic uncertainty, because it's quite hard to diagnose pneumonia properly, even when we use our stethoscopes. And the problem is, in primary care, you see patients in an earlier phase of their disease with less clear pneumonias, but still very important to diagnose them accurately and at the spot, so as soon as possible. So this followed from my thesis, where I did a diagnostic study on pneumonia to see which factors in your diagnostic process contribute the most to the proper diagnosis. And we found that the fact that we do a blood sample with one drop of blood and measure CRP, it was a much stronger predictor than anything from history taking and physical examination. And even the total of aspects from this history taking and physical examination was weaker than performing a CRP test. And particularly excluding pneumonia, and this is important in primary care, we often exclude serious disease, was possible when we have lower C-reactive protein test results. So we also concluded we need to do it at the point of care, otherwise the patient is already gone home with the recipe or with the antibiotics in their pocket. So when CRP is regarded a very sensitive and non-specific test, the doctor makes it very specific, because he knows which patient is there. Does this patient has coughing problems, or does he has stomach ache? And so the doctor knows how to interpret the CRP test result for this specific case. It's not a good idea to do a chest radiography for every patient. Well, first of all, for logistical reasons, but also because even radiologists have a hard time diagnosing those primary care pneumonias properly. So what we did, we followed up with an RCT where we combined two interventions. And if we focus on the CRP test results, we saw that if we introduce it in primary care, we actually reduced 25 or 30% of all the antibiotic prescriptions safely within the Netherlands. And the Netherlands is a very low antibiotic prescribing country. We repeated those studies on a European level, and also my colleague performed a study on exacerbations of COPD with the same result. And we went to the nursing homes, did the same study again and again. We saw the same reduction of antibiotic prescription. So now it's common knowledge. It's also summarized in various Cochrane reviews. I put it in the guideline in the Netherlands. So CRP has a central place now, and this was copied by different guidelines throughout the world, at least in some countries. And it's usual care now in the Netherlands after we've done a lot of e-learnings, speaking to many thousands of doctors. We did implementation studies, and well, I actually thought it would be a wise idea to involve laboratories to collaborate in this respect, and which was very successful. So now in the Netherlands, every GP uses CRP point of care testing as a routine diagnostic test during the day, but also during their night and weekend shifts. The good thing is, if the CRP test result is very low, this is already true for 65 to 70% of all the patients. So if you could reduce those prescriptions for people with a low CRP test results, you're already there. So when I was asked by my Ethiopian colleagues to do a feasibility study for the northern Ethiopian area around Mekelle, I thought, well, this is a great idea. At the same time, I thought maybe it doesn't discriminate severely from non-severely ill, because maybe those patients who sometimes have to walk to the clinic for a few hours are maybe all very ill. So should it help to do a CRP test result? And I also was aware of the fact that there are many other, let's say, basic patient education programs which are needed. I saw a project, washing hands project for basic hygiene. Of course, it's quite complicated to track the patients if you don't have an electronic record system. But I saw in those, when I had this field visit, which actually was excellent, and a wonderful country Ethiopia is, I saw there were not so many drugs, but antibiotics were everywhere. And that's what we saw in our results, that 88% of all the patients, whatever the cough reason was, got an antibiotic, and there was not so much place for reassurance or prescribing, for example, an anti-inflammatory drug. So is there hope? Yes, absolutely, because we saw that, like in Western Europe, the level of CRP below 20, this was true for the same percentage of patients like in Western Europe. So yes, I think if you look at the situation in Ethiopia, where I recognize that antibiotic shopping is quite common. That means that people walk to the weekly market and then go to the primary healthcare to get their antibiotics for the next month. It's a common problem. So of course we should take care of this, but it is also an opportunity to start implementation studies if there is a strong stakeholder taking care of all the aspects needed when you want to introduce a point of care test like CRP. So yeah, I feel a little bit responsible being a citizen of a country with almost the lowest prescribing rates throughout the world. I think there's room for to have some broader impact. I'm happy to say that our former Minister of Health is trying to support me with this. We ticked all those boxes you see on the left. But of course, if you want to change antimicrobial resistance problem, we need a much broader impact and much broader implementation of CRP point of care testing throughout the world. So I'm happy to be part of this, to help out, and also we need the industry, of course, and various stakeholders to make it happen. So we did some more work on different POCT methods. For example, in the Netherlands, it was not common to do HbA1c point of care testing. But we asked the patients and we asked the doctors, what do you think of it? And we actually implemented it, and they were so enthusiastic and unbelievably positive evaluation by patients and healthcare professionals. So we introduced it in various areas in the Netherlands as well. Same is true, and this is actually a study we have recently finished, that we saw that particularly the new D-dimer point of care tests were very successful in their analytical performance and also in the use outside of the central laboratory. And we found that they were as good or sometimes even better than the reference lab method for D-dimer tests, if you think of thrombosis problems So another opportunity, and I was asked to implement this in the Netherlands as well. So this will be done, I think, hopefully next year. Oh yeah, we did some other things, but I have to skip this, I think. But there are other opportunities to do better urine analysis, better professional glucose methods, and various others point of care tests, like introducing leukocytes at the point of care. I did that for certain prisons, for example, and also in psychiatric hospitals. Okay, lots of opportunities and challenges. I'm aware that we don't have in every country a primary care lab like ours, where it's more easy to collaborate with laboratory professionals to introduce and to take care of the logistics. And I also introduced an electronic model so that we can take care of quality assurance from a distance, which is really working well, but it asks a lot from IT, and it's also quite costly. So now and then. So I'm not sure if this is an option in African situation, but I talked to some African clinical pathologists, and they believe this could be easily happening in Africa as well. Yeah, if you talk about challenges, I think there's also quite a lot of rubbish, actually. When I was visiting Silicon Valley, I saw many point-of-care tests, but most of them were really rubbish if it comes to the analytical performance. So we should always take care of the quality of those opportunistic point-of-care devices which are currently being developed. It's also a challenge that we have to change the behavior of the doctors, like you see in the left side. It's sometimes hard to change a behavior which you like. Sometimes a POCT result can distract you from the real problem. So you have to keep on thinking and see your patient first, and then decide if we need an extra test, yes or no. Of course, there are issues around the reimbursement system, quality assurance, and yeah, that's about it. Let's say you can buy this house, but we need some context to show the added value of a test. So like in this respect, we have to keep on thinking and not only use CRP tests or other point of care tests randomly. We also found that it's at the current times, it's not so easy to do cardiovascular POCT with various devices, because it's too complicated for primary care situation where we have too many devices with different procedures. So there's still room for improvement also from the diagnostic industry. Lots of opportunities. We see the trend, at least in Western Europe, that we do more and more laboratory testing in the last 15 years. And I think, and that's the model I would like to bring forward in the Netherlands, should do it more decentralized, there where the patient needs it most and the doctor need it most. That means that we should keep this central, let's say, knowledge hub being a hub with laboratory professionals who collaborate decentrally. Of course, COVID has done some great things if it comes to the acceptance of self-tests and point-of-care tests. And I've seen quite some young people in the universities already trying to invent new technology, new point-of-care tests, which are really coming through the coming years. So we get almost to the conclusion. I think if we want to have a better POCT uptake in primary care, we need to find reasons per test to show doctors and healthcare professionals why we should change, why we should use a point of care testing, and then also give them some easy ways to build confidence in this point of care test, to use it routinely. Because it's not enough just to tick the boxes, because this is what was done in 2015 or 14. You see that many doctors tick boxes like, okay, I want this point of care, I want that point of care test. But in actual care, we need to help them to really start using it and to build confidence. And experiencing in let's say a feasibility study is very helpful. But then the doctors change when they start using it. They think, wow, this CRP test was great. I was reluctant before, but now I've seen it's great. What's next? I want more tests in my office. So I think this is the way to proceed. And I think there are many reasons to believe that in the coming years we get more, let's say, clusters of specific tests useful for certain hospitals or primary care organizations. And this is just been starting. And I think Wondfo is one of the companies who has already a very broad platform. And I believe this is the direction we are going in the next couple of years. For sure, the patients really love it. The doctors start to love it. And I think that holds promise for the future. Thank you very much for your attention.
Thanks, Dr. Roger. Everyone can send you your question to the chat box, and we will select one or two questions for Dr. Roger to answer. Okay, Dr. Roger, could you please answer this question? Is Jason asked, how is the adoption for POC CRP in Europe and other countries? Is there any difference in the application?
So the acceptance in the Netherlands is excellent. So like I said, it's 100% use of all GPs currently, and also nursing homes are starting to use it more often. This followed actually the situation in Scandinavian countries, so the northern countries in Europe, where it's quite common for many years to use CRP point of care testing. Switzerland is another country where it was introduced very smoothly. Currently, Belgium is taking up, Germany is taking it up, and we see in Australia some cases, but roughly throughout the world, it's still quite hard to introduce it. I know, for example, from the USA, there's kind of disbelief that it would help doctors or patients to do CRP testing. Which is hard to change, although there's so much evidence now summarized in those Cochrane reviews that it is very useful to use a point of care test. There's quite some reluctance still also, let's say, from the UK to actually implement it. Many reasons for that. Most important one, I think, is the reimbursement system. For example, in the UK, it's and they have those commissioning groups, and there's always a top priority list. And I think there's a limited amount of money there available, and you see that often it doesn't reach to the highest priority, so that's not introduced, although it was already in the guideline. So yeah, that is an issue, and I think it's important to collaborate with all the stakeholders. That's why we put out an expertise group, try to reach the world, try to reach the politicians, and I was able to give a talk at the World Health Summit, meeting a lot of politicians, and they are all aware that we should introduce it broadly in their countries. And then, yeah, the practice is still hard to change currently for many countries.
Okay. And another question is Yamarot. Yamarot asks, any observed adverse outcome in the case of decreased antibiotics prescription after POC testing?
So can you please repeat it?
Yeah, I will repeat. And the question is, any observed adverse outcome in the case of decrease and antibiotics prescription after POC testing?
Yeah. So this is which we have proven in those pragmatic primary care trials, that we could easily reduce scientifically 30% of all antibiotic prescription in Western European countries. There are also numbers of prescriptions reductions in, for example, Vietnam and some other countries in Africa, also for other diseases, not only for pneumonia, but also for tropical diseases. So yes, there's enough proof. That doesn't mean when you introduce it, like you just start using it, that it will automatically reduce those prescriptions. So you really need to take care. And that's why I put this slide on, that we need to help those doctors build confidence in a new test, to actually really believe that they can use it and they can really withhold their antibiotic prescription, because that's hard, particularly in those countries where the culture of prescribing is that much. If antibiotics are seen as a magical drug, good for everything, then we need to help to give give help to those professionals to change that behavior of prescribing. And that takes more than just introducing a point of care test. That takes more, that takes education of patients, but also education of healthcare professionals, and give them an alternative for this antibiotic prescription. That's why we also have put a lot of emphasis on this patient communication, patient-doctor communication process. So if you would ask, for example, a patient, does an antibiotic help for a viral infection? We know that half of the patients believe that it helps for a common cold. It helps for a sniffly nose. So there's a lot of work to be done at this site. Thank you.
Thank you. Thanks to Dr. Roger. Okay, then let's move on to the topic 3. Topic 3 is diagnostic approach on thyroid disorder, role of POCT in thyroid diagnosis. So let's welcome to Dr. Ahmed. Yeah.
Thank you, Gresha, for the opportunity. So what I'm going to talk about is diagnostic approach to thyroid disorders, the role of point-of-care testing in thyroid diagnosis. Again, I would like to thank the previous 2 speakers for their remarkable talk on point of care. And again, I thank Wondfo and Blue Health Ethiopia for organizing this webinar. So these are the materials that I have used for my presentation. So although I have made some of the slides, the contents of the slides were taken from this material. So by way of disclosure, I would like to mention that I have used these references for my presentation, and I would like to acknowledge and thank the authors of the review and research articles. So this is the outline of my presentation. So I will be talking about the anatomy of the thyroid gland and briefly talk about thyroid hormones and their control by the hypothalamic pituitary thyroid axis. And then I will give you an overview of thyroid disorders. And then I will talk about thyroid function testing, and then point of care testing, and then I will give you summaries. So these are the objectives of my talk. So I hope by the end of this talk, you will understand the diagnostic approach to thyroid disorders and explore the role of point-of-care testing in thyroid function testing, and then evaluate the advantages and limitations of point-of-care testing in clinical practice. So let's talk about the anatomy of the thyroid gland. As you know, the thyroid is an important endocrine organ that is situated on the anterior part of the neck, just below the cricoid cartilage between the 2nd and 4th tracheal rings. What is interesting about the thyroid gland is it's the first endocrine organ to develop in the human embryo, and it has a shape of a butterfly, and it has 2 lobes, the right thyroid lobe and the left thyroid lobe. Sometimes there is a third lobe, pyramidal lobe in certain individuals. Otherwise, it's made up of two major lobes. And there are two types of cells, follicular cells and parafollicular cells. The follicular cells are the ones that are important for the synthesis of thyroid hormones. The other important structures surrounding the thyroid are the parathyroid gland. If you look at this picture, which is taken from behind, there are 4 parathyroid glands, and there is also recurrent radial nerve. Now, the thyroid gland produces 2 biologically active hormones, thyroxine or tetraiodothyronin, the T4, and triiodothyronin, the T3. T3 and T4 are important for the neurological development and physical growth of fetus, infants, and children, and have many important action on the metabolism in adults. Follicular cells synthesize thyroglobulin, which serves as a precursor of thyroid hormones. As you know, many endocrine glands secrete their hormones as they are produced. Thyroid is unique in that it stores a considerable amount of thyroid hormones in the colloid and releases them into circulation as needed. And 90% of thyroid hormone produced by the thyroid is T4. And what is important in the synthesis of thyroid hormone is tyrosine and iodine. T4 is the main hormone synthesized in the thyroid gland, but it has little affinity to cellular receptors as compared to T3. So T4 basically serves as a precursor prohormone for T3. T3 is the most biologically active, and only 20% is synthesized in the thyroid and 80% in peripheral tissues. Now, this is a slide about the synthesis of thyroid hormones. You don't need to remember everything in this slide, but suffice to say what is important for the synthesis of thyroid hormones is iodine and tyrosine. So in the first step, what happens is iodine is trapped by the thyroid follicular cells, iodine which we get from our food or water, and then the iodine diffuses to apex of the cell, and then it's transported into the colloid. And then what happens is organification of inorganic iodide to iodine, and it's incorporated into tyrosine residues within thyroglobulin molecules in the colloid. Now, when the two combinations of two diiodothyronin molecules to form tetraiodothyronin or monoiodothyronin with DIT will form triiodothyronin, 3 iodine molecules. So the thyroglobulin from the colloid will be taken by the follicular cells by endocytosis, and then there will be proteolysis and release of T4, T3, DIT, and MIT. Now, release of T4 and T3 happens into the circulation, and then T3 is also formed from monodeiodination of T4 in the thyroid. So as I said, this is a little bit complicated, but what is important is we need iodine and thyroglobulin for the synthesis of thyroid hormones. Now, thyroid hormones exist into two forms. Because they are poorly soluble in water, they have to be transported bound to plasma proteins. And 70 to 80% of thyroid hormones are transported by thyroxine binding globulin. The other transport proteins are transthyretin and albumin. So the bound forms are not the ones that are active. It is the free forms or the unbound thyroid hormones that exert their biological effect. So although total T4 and T3 may be low or high, the free hormones are unaltered, so individuals are generally euthyroid. But there could be some factors that would increase thyroxine binding globulin or decrease thyroxine binding globulin. Therefore, one should take into consideration when interpreting thyroid function tests this issue of increased or decreased thyroxine binding globulin. But in any case, these days, what we are measuring is free hormone levels. So basically, this will not be changed. So the regulation of thyroid hormone is quite complex. As you can see on this slide, what happens is the growth and function of the thyroid gland is controlled by the hypothalamus pituitary thyroid axis. Now, the hypothalamus produces thyrotropin-releasing hormone, TRH, which stimulates the thyrotrophs of the anterior pituitary gland to produce thyroid-stimulating hormone. Thyroid-stimulating hormone is needed for the thyroid growth and secretion of thyroid hormones. In fact, TSH has a pulsatile secretion and diurnal variation. So changes in the level of thyroid hormones have an effect on the pituitary, as you can see on this slide, and on the hypothalamus, depending on the level of the hormones, which I will be discussing later on. So T4 is converted in the peripheral tissues, mainly in the liver and kidney, to the active form of T3. So the thyroid hormones are very important and for our existence, and they have multiple effects on almost all tissues and organs. They stimulate oxygen consumption and increase metabolic rate. Thyroid hormones are important for fetal development and growth. It's important to remember that in the initial period of gestation, the fetus gets thyroid hormones from the mother, but by 10 to 12 weeks of gestation, the fetus starts to produce its own thyroid hormones. So this is important because before conception and in the first few weeks of gestation, it's important the mother is euthyroid in terms of her thyroid status. Thyroid hormones have effect on lipid, protein, and carbohydrate metabolism, and they have both inotropic and chronotropic effects on the heart and promote normal growth and skeletal and brain development, and they stimulate formation of LDL receptors. So what are the common thyroid disorders? Thyroid-related disorders are common worldwide, and they are very readily treatable, but one needs to make the correct diagnosis because most of the symptoms could be non-specific, so it's important that you make the diagnosis. But once you make the diagnosis, they are really treatable. But misdiagnosis could lead to infertility, to osteoporosis, and cardiovascular diseases. So in general, there are about 5 types of thyroid disorders that are important. Hypothyroidism, which is characterized by insufficient thyroid function, hyperthyroidism, excessive thyroid activity, and simple goiter, single nodular or multinodular in euthyroid state, and thyroid nodules, which could be benign to malignant, and of course, thyroid cancers. I'm not going to go into the detailed discussion of these disorders, but suffice to say, the thyroid disorders have significant impact on individuals' general health and well-being. So let's talk about hypothyroidism, which is more common than hyperthyroidism, and it's very difficult to make the diagnosis of hypothyroidism in clinical practice. Most patients are diagnosed very late. So hypothyroidism is deficiency in thyroid hormone production or secretion, and it has a variety of clinical signs and symptoms of hypometabolism. It could be overt hypothyroidism or subclinical hypothyroidism, but both are associated with adverse cardiovascular outcome. So if you just look at the hypothalamic pituitary thyroid axis, whenever there is a hypothyroidism characterized by low thyroid hormones, the message sent to the pituitary and to the hypothalamus is to increase the secretion of TRH and TSH. So the diagnosis of hypothyroidism will be based on low T3 and T4 and increased TSH. This is extremely important. So high TSH would indicate hypothyroidism. But sometimes there is what we call subclinical hypothyroidism, which is characterized by raised TSH and normal free T4. Symptoms of hypothyroidism are very non-specific, and they may mimic many other serious diagnoses like anemia, chronic fatigue syndrome, malignancy, cognitive dysfunctions, affective disorders, even acute psychosis. So rapid recognition of hypothyroidism facilitates timely treatment and can prevent further unnecessary testing. So the symptoms and signs are depicted on this slide. Basically, most of patients with hypothyroidism would complain of weakness, lethargy, cold intolerance, hoarseness, dry skin, hair loss, and anorexia, and constipation. And some women may complain of menstrual irregularities. So as you can see, these symptoms can be present in many, many conditions. So they are not really each one of them is not specific for hypothyroidism, but when you have a constellation of these symptoms plus signs like goiter or bradycardia, bradykinesia, then you may suspect hypothyroidism. One important sign is loss of the outer lateral eyebrows, the so-called Queen-Anne sign. Sometimes patients may have carpal tunnel syndrome or delayed relaxation of deep tender reflexes, and they may have also galactorrhea, psychosis, and in severe forms, they may have even coma. And then if diagnosis is not made in neonates and babies, there may be growth failure and mental retardation, which is really a preventable cause. So when we talk about hypothyroidism, we talk about two types of hypothyroidism. Primary hypothyroidism, characterized by high TSH and low T4. This is the commonest form of hypothyroidism. And there are several causes, but worldwide, iodine deficiency is the commonest cause for primary hypothyroidism, whereas in the developed countries, chronic autoimmune thyroiditis would be the major cause for primary hypothyroidism. So it is characterized by high TSH and low T4, and treatment is very simple with levothyroxine once you make the diagnosis and you follow patients with TSH. Central hypothyroidism or secondary hypothyroidism is due to pituitary disease and hypothalamic diseases. So it is characterized by low TSH again and low T4 because there is impairment from the hypothalamus and the pituitary. Treatment is again with levothyroxine, but you follow it with free T4. Sometimes you can also have transient hypothyroidism due to silent thyroiditis, including postpartum thyroiditis and subacute thyroiditis, which are really rare, but one needs to be aware of these conditions as well. When it comes to hyperthyroidism, which is less common than hypothyroidism, what happens is there is excessive thyroid hormone production and or secretion, and it produces a variety of clinical signs and symptoms of hypermetabolism. Again, there could be overt hyperthyroidism characterized by low TSH and high free T4 and free T3, but sometimes, particularly in the elderly, you can have subclinical hyperthyroidism characterized by low TSH but normal free thyroid hormones. But suffice to say, both are associated with adverse cardiovascular outcomes. As you can see on this slide, Hyperthyroidism characterized by high thyroid hormones, free T4 and T3, will send message to the hypothalamus and pituitary to reduce the production of these stimulatory hormones. Therefore, the TSH will be very low. Again, the symptoms of hyperthyroidism on their own may not be sufficient to diagnose hyperthyroidism, but if you have a constellation of symptoms and signs, you may suspect hyperthyroidism and do appropriate investigations. So symptoms are like palpitation, sweating, heat intolerance, tremor, and increased appetite, but patients would lose weight. So weight loss, despite increased appetite, is one feature that may help you to make the diagnosis of hyperthyroidism. And they may have increased bowel motion, hyperactivity, fidgety, and weakness. They may have tachycardia and atrial fibrillation, particularly in the elderly. Atrial fibrillation on its own should make you, unless there are clear-cut causes, should make you suspect hyperthyroidism in the elderly. They may have also systolic hypertension. The skin would be warm and moist, and they would have stare and eyelid retractions, hyperreflexia, muscle weakness, goiter, which could be diffuse if it's in Graves' disease, or nodular in toxic nodular goiter or toxic multinodular goiter. Sometimes in Graves' disease, they may have thyroid bruit, which is a very sensitive test, exophthalmos, and pretibial myxedema. Causes are varied, but the commonest cause is Graves' disease, but there may be toxic adenoma and toxic multinodular goiter, particularly in the developing countries where the iodine deficiency is very high. We need to think of toxic adenoma and toxic multinodular goiter. Sometimes you can also have subacute thyroiditis following, or decurvant thyroiditis following some viral infections. This is destructive thyroiditis. And a certain group of women could have postpartum thyroiditis. And one other important cause of hyperthyroidism is HCG-induced thyrotoxicosis. These are the more common than the TSH-secreting pituitary adenoma or central, hyperthyroidism characterized by high TSH and high T3 and T4. And certain drugs like amiodarone could also be cause for hyperthyroidism. Graves' disease is the commonest form, which has very clear symptoms and signs. So it is usually characterized by high T3 and T4 and low TSH. It is treated with antithyroid drugs or radioiodine or surgical removal of the thyroid gland. Follow-up of Graves' disease is with free T4 and T3 and TSH. But remember, the TSH value may not revert to normal for weeks and months. So as long as the free T4 and T3 are normal, then patients could be regarded as euthyroid. Toxic multinodular goiter and toxic adenoma are more common in elderly people and in iodine deficient areas. And they are characterized by low TSH, high T3, and T4, but they may not be as marked as in Graves' disease. And older patients, as I said earlier, are prone to atrial fibrillation. And of course, we need to give definitive treatment for patients with toxic multinodular goiter or toxic adenoma, be it radioiodine or thyroidectomy. Because in Graves' disease, once you give them antithyroid drugs, some patients may go into remission and they may be spared from surgery or radioiodine. Now, subclinical hyperthyroidism, as I said earlier, is characterized by low TSH, but normal T3 and T4. Of course, it's a risk factor for cardiac diseases, but treatment should depend on the age and symptoms and also TSH levels. Thyroiditis, there are several forms of thyroiditis. Some of them have autoimmune etiology, and some may cause thyrotoxicosis or hypothyroidism or both. So in certain situations, thyroiditis may eventually progress to permanent hypothyroidism, and risk is higher in those with high serum thyroid antibodies. And this is quite high in women and in older people. Hashimoto thyroiditis is one of autoimmune origins, and it is very common in the Western world. And it is diagnosed based not only on based on thyroid hormone, but on the presence of autoantibodies against TPO. And TSH should be used for monitoring, as I said earlier, and serum thyroid antibody concentrations should also be determined, but they may not decrease with treatment. Postpartum thyroiditis develops in the first 12 months after delivery, and some may have triphasic pattern, but thyrotoxic, then normal, and then they may have hypothyroidism, or some may just have hypothyroidism or hyperthyroidism only. And in this situation, TSH is the one that should be used for monitoring. And usually it is self-limited, and symptomatic therapy is what is needed. So beta blocker sometimes can be used if thyrotoxicosis is severe, but if thyroxine is very high, more than 10, then one may opt to use thyroxine for a certain period of time. So what are the diagnostic approach to thyroid disorders? What is important is comprehensive evaluation, that is complete history, including family history, risk factors, and thorough examination for thyroid size, nodules, and tenderness. Thyroid ultrasound, fine needle aspiration, and thyroid scintigraphy are important. But I'm not going to talk about all this. My common topic is laboratory tests of thyroid function, that is thyroid stimulating hormone determination, free T3 and free T4 levels, and thyroid antibodies. Now, these are the tests that can be done to evaluate the function of the thyroid: TSH, free T4, sometimes total T4, and free T3. Certain laboratories also determine total T3. And thyroid antibodies, TSH receptor antibodies, thyroid peroxidase antibodies, and thyroglobulin antibodies, which become very important in the follow-up of patients with thyroid cancer. And then thyroglobulin, the same holds true. It's important in follow-up of patients with thyroid cancer, and thyroxine binding globulins are also tests that can be done to evaluate thyroid functions. So thyroid function tests have shown remarkable improvements since the 1950s, and many methods have been used to measure thyroid hormones and TSH in plasma or serum. And it's really improving lately because of automated platforms and progress in immunoassay, molecular testing, and automation. And these days also, people are trying to introduce artificial intelligence. So, but what are the challenges and pitfalls of interpreting thyroid function tests? Because there are differences in age, sex, and physiological conditions, and underlying medical problems influence thyroid hormone levels. We don't have really universally applicable reference ranges. Certain laboratories give you different reference ranges. And for example, during pregnancy, you have to use trimester-related reference values, but most labs do not give you. And the other challenge is non-thyroidal disorders cause changes in hormone levels, making it difficult to interpret thyroid function tests. And the limitations of traditional diagnostics are delayed results from central lab testing. I know in many resource-limited countries, thyroid tests take days until the lab accumulates certain number of tests to do the testing. And it will be very challenging to have lab-based tests in rural or resource-limited settings. And of course, patients will have multiple visits for their results. So what are the tests that are important to assess thyroid function? It is the serum TSH concentration and serum free T4 and T3 concentrations. And it's important that you precisely diagnose thyroid function because it is important for diagnosis and treatment. If you inappropriately diagnosed or insufficient monitoring, it would affect the health of individuals. So I see in our country, many doctors send just total T4 and T3 without sending TSH. This will be very confusing. So the first test that we need to do is TSH testing. It is the first line of assay for assessment of thyroid functions in various conditions. We don't need to do initially the other tests because primary thyroid disorders can be diagnosed with TSH testing. I will be telling you when to use T4 and T3. But in general, if you don't suspect hypothalamic or pituitary disorder, TSH testing is suffice. And patients present, when can you use TSH testing? For those with symptoms of hypothyroidism, patients with suspected goiter, and patients presenting with dyslipidemia, because hypothyroidism could be the cause for dyslipidemia. So before you embark treating the dyslipidemia, it's good to rule out hypothyroidism. And then women with postpartum thyroiditis could also benefit from TSH testing. Patients with type 1 diabetes, in fact, it's recommended to have yearly testing of TSH for patients with type 1 diabetes. Patients with Down syndrome, Turner syndrome could also have TSH testing, and those on amiodarone, on lithium therapy, or those who had external neck irradiation, and those who had radioiodine or thyroidectomy, and those who are on antithyroid drugs for hyperthyroidism should also be followed with TSH testing, and patients on thyroxine therapy would really need TSH testing. So if you don't remember what I said earlier, the three important uses of thyroid function tests are evaluation of thyroid dysfunction, assessment of adequacy of levothyroxine therapy, and monitoring of treatment of hyperthyroidism. So in the outpatient setting, what should you do? If serum TSH is normal, then no further testing needs to be done, okay? You have to look for other causes for the symptoms of the individual. But if serum TSH is high, then you could add free T4 to determine the degree of hypothyroidism, whether it is overt or subclinical. If serum TSH is low, free T4 and free T3, sometimes because there could be T3 toxicosis, to determine the degree of hyperthyroidism. You would measure both serum TSH and free T4 only if pituitary or hypothalamic disease is suspected. For example, a young woman with amenorrhea and fatigue, she may have pituitary disorder. So measure serum free T4 if patient has symptoms of hyper or hypothyroidism despite a normal TSH result. In the inpatient setting, what needs to be remembered is in seriously ill inpatients, you don't need to determine thyroid function test unless you have a high index of suspicion, because changes in thyroid hormones, binding proteins, TSH concentrations could occur in severe non-thyroidal illness, and you will have difficulty in interpreting thyroid function tests. Therefore, don't determine unless you have a high index of suspicion of thyroid dysfunction. How do you monitor primary hypothyroidism? Assess serum TSH only. You don't need to determine T4 or T3. In secondary hypothyroidism, due to pituitary or hypothalamic disease, use serum-free T4 value as there is absent or impaired TSH release. In hyperthyroidism, during early treatment of hyperthyroidism with anti-thyroid drugs, radioiodine, or surgery, serum TSH may remain subnormal for several weeks and rarely for several months. Therefore, initial monitoring of therapy should consist of periodic clinical assessment and measurement of serum free T4 and T3 levels. Thyroid disorders, this brings me to thyroid disorders and pregnancy. Thyroid disorders are the second commonest endocrine disorders in pregnancy after diabetes. And it's important to be aware of the physiological changes occurring in thyroid function during pregnancy. Hyperthyroidism in pregnancy is usually caused by Graves' disease, and both subclinical and overt hypothyroidism have adverse outcomes. As I said earlier, maternal reserves of the thyroid hormone covers the need of the fetus brain development until the fetus can synthesize its own hormone at 12 weeks of gestation. Therefore, one must ensure that mother is clinically and biochemically euthyroid at the time of conception and in the first 3 months of pregnancy. In many parts of the world, there is mandatory screening of newborns for congenital hypothyroidism with spot TSH testing, which helps to prevent mental retardation due to early treatment. In resource-limited settings, for example, in my country, due to unavailability of newborn screening, there is still risk of hypothyroidism in newborns. Wider availability of point-of-care testing in rural and resource-limited settings would have a greater role in newborn screening with point-of-care TSH testing. Adverse outcomes of hypothyroidism and for the mother and the fetus are really serious conditions, so it's important to make timely diagnosis. So point of care, you have heard a lot about point of care testing, particularly Roger dealt with in detail in an excellent way. So just few points. Point of care testing involves testing at the point of where the patient receives medical care away from a central laboratory. And the common testing locations could include patient's bedside, physician's office, patient's home, ambulance, or emergency room. You remember the availability of bedside monitoring of glucose has markedly changed the management of diabetes. Now we're talking about the point of care testing in thyroid dysfunction, which could be very important. So the first point of care thyroid diagnostic, a qualitative TSH immunochromatographic assay was US FDA approved in 1999. So point of care quantitative TSH, T4 and T3 assays are currently commercially available in many countries. And their benefits, cost-effective, low cost, saving in venous section time, lab time, transportation of samples, ease of manipulation, rapid turnaround times, results are ready in 10 minutes or so, patient satisfaction, avoidance of unnecessary venous section, reassurance of an immediate negative result, and also reduced sample volume requirements. The other benefit of point-of-care testing is that negative results allows clinicians to consider other explanations. And sometimes conditions that require an immediate diagnosis, especially in newborns or in emergency situations where you're not sure what is going on with the problem, you could use point-of-care testing in preference to lab-based tests. And this would be more important in resource-limited settings where you cannot have highly sophisticated lab tests in the rural areas. In rural settings, if you have point-of-care testing, it would really prevent needless referrals to specialized medical centers. So the limitations have been already discussed by Roger, so I will not go into that. But let me just to wind up, give you how we can use point-of-care testing by presenting a case. For example, a 45-year-old female presenting to you with fatigue and weight gain, and you inquire also about cold intolerance, and patient says she has cold intolerance. So you would suspect in such a constellation of symptoms, hypothyroidism. So if you have a point of care testing, wherever you are, you could do the TSH test on the site. And if you find it elevated, say 8.5 with those symptoms, you have the diagnosis of hypothyroidism, and you can make an early diagnosis and treatment for hypothyroidism. So in summary, thyroid disorders are common problems worldwide. Undiagnosed and untreated thyroid disorders have adverse outcomes. Comprehensive diagnostic approach is critical for early treatment of thyroid disorders. Point of care testing offers significant benefits in speed and accessibility. Technological advances are improving sensitivity and specificity of point of care testing devices, and lately integration with artificial intelligence could enhance our diagnostic accuracy, and global adoption, expanding access in resource limited settings would be very, very important. Also, there could be some limitations, but advancement continues to improve the utility of point of care testing. Thank you for your attention.
Thank you, Dr. Ahmed. Thank you, Dr. Mohammed. And if anyone have any question you can send the question to the chat box, and we will select one or two questions to ask Dr. Ahmed to answer.
There is one question.
Yeah, that's with one question. Dr. Ahmed, could you please answer the question?
Yeah.
Are there any study or data that demonstrate the long-term benefit of using POCT for managing thyroid condition?
Yeah, no, these are, we don't have in our country or in resource limited settings. These are just coming to the picture. So we would need to have our own studies on the long-term benefit and vis-a-vis, but there are some studies from Nigeria that have really shown the benefit of point of care testing as compared to labs. Of course, we'd have to do our own studies in Ethiopia.
Okay. And another question is Johannes asked, is that possible to be pregnant for patient who has been diagnosed with chronic hyperthyroidism?
Oh, yes, absolutely. What we need to do is we have to treat the hypothyroidism, and the TSH value should be around 2 to 2.5 so that we have a better outcome. So treatment with thyroxine is extremely important before conception to render the lady euthyroid before conception. And in the first few months, up to 12 weeks, in fact, we may need to increase the dose of thyroxine so that the thyroxine also supports the fetus. So once they are euthyroid and TSH is around 2 to 2.5 milli-international units per liter, then you could allow the lady to become pregnant. And pregnant, they should be followed very thoroughly throughout pregnancy, making sure TSH is not rising. In fact, it is suggested to increase the dose of thyroxine by about 20% or 30% in the first few weeks of conception.
Okay, thank you, Dr. Ahmed. And I think some of the audience are from Blue Health Ethiopia today. So Blue Health Ethiopia is founded with the aim of promoting healthcare. So let's welcome to Blue Health Ethiopia.
All right. Thank you very much. I'll be introducing Wondfo Ethiopia. So Wondfo Ethiopia is a medical consultancy company founded by medical doctors and computer engineers, and we aim to be an influential healthcare leaders in creating a skilled community through easily accessible knowledge and preventive medicine. And this is the 112th Blue Hills Virtual Seminar, and Blue Hills Virtual Seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And we would love to thank all the panelists for joining on the 112th Blue Hills Virtual Seminar, and we hope to have them in future virtual seminars as well. So for participants, you can follow us on our social media channels, including Telegram, Instagram, and YouTube for future virtual seminars. And those of you who previously missed previous Blue Hills virtual seminars, you can access them on our YouTube channel as well as on the Blue Hills CPD website, where you can access multiple lectures from different physicians on various topics, and you can earn a 1.5 CEU CPD certificate for each virtual seminar that you attend and score 60% and above on the quiz. So, dear participants, for today's virtual seminar, I will be posting the link to the quiz in the chat box, and those of you who are going to be scoring 60% and above will be eligible to receive a 1.5 CEU CPD certificate. And today's virtual seminar is for free, which is sponsored by Wondfo. And thank you very much for taking the time to present on such a wonderful topic.
Thank you. And PHU will send the exam link inside in the chat box, and please complete it and submit the exam for CEO point. Okay, that's today's webinar. Thanks to the 3 doctors for a great discussion for the role of point of care testing in primary care. And special thanks to our speakers today who deliver very informative talks today. Dr. Getahun, Dr. Ahmed, who joined us from China, and Dr. Rogier, who joined us from Netherlands. So, and get up very early to join us. Thank you very much, Dr. Rogier. It's our honor to have you with us today. Thank you.
Thank you all.
Yeah, thank you. And if you have any further question, please send to this email. I will share this email. Okay, and later you can issue certificate each participant. Please check your email. We will send the certificate to your email. And see you next time. Bye bye. See you next time. Have a nice day.